When Linda approached me about talking to you today, she did explain that my role here is to give a little bit more information under the numbers that are thrown out. And she did tell me that the title of the presentation was behind the headlines. And I did the same thing. I Googled Providence Journal, Providence Business News for some headlines. But they were too depressing, so I don't put them in. The best one was, it was my picture, and above it, the headline was, "Medicaid numbers are confusing." So, yes. So I want to talk a little bit about the Medicaid spending, who we spend Medicaid funds on, providers, and then also how much we're spending. I'll talk a little bit about the 2013 governor's proposed budget, and then just a few minutes on the recently released President Obama's 2013 proposal and any potential impacts that federal proposal might have on Rhode Island's medical assistance. So I just want to talk first about what do I mean when I say it's a Medicaid expenditure? Because what makes an expenditure Medicaid versus non-Medicaid is really the presence of federal matching funds. So we have, over the years, really decreased spending that is solely general revenue spending only. There have been very deliberate attempts to ensure any health care expenditure is matched by Medicaid funds. And the most recent effort to do that has been through our 1115 Global Waiver. Some of you are familiar with an aspect of that waiver, which is, we refer to it as costs not otherwise matchable. And it is an attempt by the state of Rhode Island to say to the federal government, here are a group of expenditures that most states are making with general revenue funds only. We think that it is in the best interest of both the federal government and the state to have access to federal Medicaid matching funds for those expenditures. We want to test this out and see if it makes sense. So examples of those expenditures are behavioral health needs for individuals who are currently uninsured, who cannot access Medicaid for income reasons or they're childless adults. We are now, as a state, receiving federal Medicaid matching funds for some of those behavioral health treatments. And it's around 20 million, 20 to 30 million, depending on which year you're looking at, 20 to 30 million influx of new federal funding. So it's an important point because I work for the EOHHS Medicaid program, but the budget that we have is not the only budget for which federal Medicaid matching funds are available. So as Linda mentioned, BHDDH receives federal Medicaid matching funds, as do DCYF, DHS, and the other agencies. I will focus in my talk primarily on the appropriations that come to what is now EOHHS Medicaid. This slide covers the gamut. It's people served by all agencies. And you'll see that the majority of people served by the Rhode Island Medicaid program are children and families, 68%. And I have the state fiscal year 2010 numbers and then just a snapshot from last month to show you that we are experiencing some enrollment growth in some populations, but not across the board. Enrollment has gone up slightly, but has pretty much stayed the same. So we've got the next largest group are adults with disabilities. These are adults 21 to 64 years old who either receive supplemental security income or are determined to have a disability by our eligibility office. And then 9% are elders, people over the age of 65. And then we have children with special health care needs, and we include in that population children who are eligible through our Katie Beckett program children who are in adoption subsidy programs. So what do we provide? Usually when I answer this question, I have a list of the mandatory services, optional services, but because this presentation is really about budget, I wanted to present this to you in the way in which we have to present our expenditures to the Budget Office and the House and Senate Finance Committees. So our expenditures are organized really around these 6 large line items: hospitals, and these are expenditures that we make direct payment to hospitals. Long-term care includes nursing homes, hospice providers, and home and community-based services. So that would be home health agencies. That includes our personal choice, self-directed program. Pharmacy. Rhode Health Partners is our Medicaid managed care option for adults with disabilities, and our the two managed care organizations that we contract with for that product line are United Healthcare and Neighborhood Health Plan of Rhode Island. The managed care line is Right Care and Right Share. And then we have a large group of other, which would include Medicare premiums. These are premiums that the state pays for people who are eligible for Medicare and whose income is such that the state provides assistance paying for that Part B premium and a copay and coinsurance. Transportation, durable medical equipment, and rehabilitative services. So again, this concept of Medicaid moving from the Department of Human Services to the Executive Office of Health and Human Services certainly makes a lot of sense when you think about the reach of Medicaid and the role that I play in relation to, say, Director Stenning or Director DeFrancis is they have statutory authority to develop their programs. So Director Stenning has a statutory authority to build the system for individuals with developmental disabilities, and he receives an appropriation from the General Assembly to administer that program. Where I come in is to ensure that the federal Medicaid funds that he's been appropriated are in fact being claimed correctly. So my office is the office that certifies to the federal government that in fact any federal Medicaid match received by the state of Rhode Island for expenditures under BHDDH are in fact compliant with federal rules and regulations. And we work very closely with all of the departments under EOHHS to make sure that those requirements are met and they're embodied in interagency agreements. But this shows the breakdown, and so my slides are a little bit more up to date. We're assuming certain things are going to pass in this current budget, in this current legislative session. So EOHHS actually represents the medical assistance portion at $1.4 billion, and then BHDDH Medicaid budget is around $400 million, and then DCYF is next with $50 million. And this slide just again shows what the Medicaid, again, the expenditures that are matched with federal Medicaid funds, the portion of that across the entire budget. I do want to make a point about the existence of the federal Medicaid match, and we're currently matched at a 52.5%. We have a higher matching rate for certain children and pregnant women, and that's a CHIP rate. And this is important to note because I'll talk a little bit later about some changes that the federal government is proposing to the FMAP rates. We call these federal medical assistance percentages FMAP rates. So, and just one other point about the FMAP, it's important for people to understand that the federal funds are also appropriated by the General Assembly. So we talk about total funding when we're talking about, say, cuts. But there is a focus on the general revenue spend, and the conflict or the challenge with Medicaid is cutting Medicaid expenditures does reduce the general revenue, but it does also cause the state to lose incoming federal revenue. So we are the largest receiver of federal funds because of the Medicaid program. So that is always a challenge. I want to spend a little bit of time on this slide. This shows you the populations covered by Rhode Island Medicaid, and then the expenditures and the variance. So this is a slide I think that many people are familiar with. It shows that the largest group of enrollment, the children and families, actually cost the least amount. So we've got 26% of our expenditures flowing for 68% of the population. So the rest that are left are the elders and the adults with disabilities and children with special health care needs. So the majority of expenditure goes, again, to the lowest number of people. Our per member per month cost for elders is around $2,000 per member per month. For adults with disabilities, it's very similar. It's a little bit lower, around $1,900. For children with special health care needs, it's about $1,300. And for children and families in our Right Care program, it's closer to $300 in the aggregate. So very comparable to, and I think better in some situations than commercial. I want to talk a little bit about the growth in expenditures. Overall, the growth in Medicaid spending has been about 2.5%, but that is reflective of two things. That's reflective of actual costs and also enrollment. So our costs have stayed relatively steady on average. It does differ a little bit between population groups, as you see from the slide. But the real driver over the last, between the period of 06 to 10, really has been enrollment. That's been the main driver for our costs. Our enrollment was pretty constant between 06 and 09, and then we started to see it bump up again pretty much because of the economic situation, 09 and 10. And we're seeing it level off a little bit, but enrollment has driven our costs. And the 2.5% trend is very is low when you compare it to what the national Medicaid growth trends are at 3.8%, and then nationally the commercial growth is 5.3%. So despite the notion that Medicaid spending is out of control, it is actually lower than what you find in other healthcare markets. So I want to talk a little bit specifically about spending by line item. I won't go into this too much, but just to give you a sense of where how much money we are talking about. So the 2012 enacted budget was $1.6 billion. I always have to gasp a little bit at that number. The majority of it goes to paying institutional providers, hospitals, and long-term care facilities, but that includes the community-based services. So the hospital line includes outpatient and inpatient claims at about $100 million. These acronyms, upper payment limit and uncompensated unqualified care, and DSH stands for disproportionate share hospital. Those are all payments intended to address any charity care that hospitals provide or the gap between what Medicaid provides and costs. Long-term care, we spend about $341 million on nursing facilities and hospice. Nursing facilities alone is around $320 million of that. And then on the long-term services and supports, we're spending about $74 million. We are trying to, over time, increase that amount. I just want to, am I good on time? I'm not, okay. The pharmacy spend, this is pharmacy where the state is paying directly. It's very low because the majority of our members or our Medicaid beneficiaries are enrolled in managed care organizations, and in Rhode Island, the managed care organizations manage the pharmacy benefit. Clawback is the amount of money that we pay the federal government to account for Medicare Part D. Rhode Health Partners is costing us about $190 million, and then managed care, again, the Right Care program is $620 million. And the other, that would be transportation, durable medical equipment, et cetera. So for the 2013 budget, we were, again, trying to address budget deficits. So I want to talk a little bit about some of the ways that we have proposed to address those deficits. And we're trying to do these under some guiding principles. The first is ensuring that the system is sustainable, the whole health and human services system. So some of the examples of budget initiatives that we're pursuing to ensure sustainability are through BHDDH, which is a third-party liability initiative, ensuring that if a person has other coverage, either through Medicare or commercial coverage, that coverage is pursued first and Medicaid pays last. BHDDH is also pursuing some more health home models. You may have read about the existing CMS-approved health home model for behavioral health organizations, and BHDDH is continuing their success in pursuing that model through the potential of a health home model for individuals with developmental disabilities and also for people receiving methadone treatment. In our budget, EOHHS Medicaid, we have instituted, or we will be instituting, administrative reviews, additional clinical utilization reviews for children with special health care needs and people receiving services in the community. Estate recoveries addresses an effort to ensure that if a person has received services paid through Medicaid, that their estate pays its fair share. Another theme that we're pursuing is an investment in the administration and operational existing resources. So for example, we have a surveillance and utilization review contract for hospitalizations and other services. We would expand that. A large chunk of the budget savings are coming from changes to our managed care contracts. So a little bit over $32 million, and again, these are all funds, both general revenue and federal funding, will be seeking to remove from the managed care contracts. And this change is really a reflection of, I think, the very good job that the managed care organizations have done to date in managing care, and an expectation that that can be done even better. So we've provided some tools to do that. We'll be working with the managed care organizations, for example, to receive CMS approval so that nutrition education can be provided. But we're also looking to the managed care organizations to use the tools that they already have to reduce those expenditures. We are also finding, because of the situation, that we just need to make some very difficult decisions that I can't argue with in terms of the wisdom of making these cuts, but they're necessary. So specifically, the adult dental benefit. We are proposing that that be eliminated for this coming budget year. So that would affect about 36,000 utilizers of an adult dental benefit. There are potential 90,000 adults who could access it, but this change seeks to save close to $6 million with an October 2012 implementation date. We're also cutting reimbursements to hospitals, nursing homes, and durable medical equipment. While we're making these cuts, we don't currently have any initiatives in play specifically around payment reform, but we have been over the last few years really looking at the way we pay institutions and our managed care organizations, and ensuring that the way we pay for services is reasonable and will match our policies. So for example, over the last few years, we have moved from paying hospitals on a cost basis for inpatient care. For many years, we did pay hospitals their costs. And we've moved now to pay what's called an APR-DRG methodology, which says no matter which hospital a Medicaid beneficiary goes to, if they go into that hospital for X service, each hospital will receive the same amount of money. And we're pursuing that also with our payment methodologies for nursing facilities. For 30 plus years, we had been paying nursing facilities, again, based on cost. In 2010, we moved to adjust that cost-based reimbursement slightly to account for the acuity of nursing home residents, and what we are striving to move to is a payment methodology that recognizes the needs of nursing home residents and pays nursing home facilities based on those needs, not necessarily on the costs incurred by the nursing facilities. So I just want to close with some aspects of the president's budget that are a little bit concerning. Anytime the federal budget comes out and there are significant decreases to Medicare, we are concerned that it's going to result in a cost shift to the states. So one of the ideas in the president's budget is what's called a single blended FMAP. So this gets back to the slide I had about the federal Medicaid matching rates is 52% and 66.8%. What the president is proposing is to blend both the Medicaid and the CHIP rate so that we have an average FMAP rate, and it's based on enrollment in 2014, and it will be effective in 2017. So Rhode Island takes full advantage of that enhanced CHIP match. So we have to do the analysis to see what the impact is, but the other changes are a restriction on provider taxes, and this has concerns for us because provider taxes are one of the sources of revenue that funds the Medicaid program. Federal government is also looking to rebase the disproportionate share hospital, and that would reduce the amount of funds available to pay for charity care, et cetera. It's going to allow states to implement benchmark benefits. It's not clear what that means yet, but it will allow states a little bit more flexibility in drafting which benefits are available to beneficiaries. There are a lot of program integrity provisions in the budget, and then there's Medicare initiatives such as increased copays for home care. And again, a concept like an increased $100 copay for home care for people who have both Medicaid and Medicare, that is a direct increase in costs for the Medicaid program. So that would concern us a bit.